I would like to thank the speakers and then invite the next set of speakers to the podium. The next is going to be a mix chaired by Dr. Ernest Anite from Ghana and Professor Etioma from Nigeria. Shall they come upstage? We are going to have Dr. Henry Badu, Mr. Vanamuzu, Mrs. Margaret Yeboah.
We'll call the first speaker, who is Dr. Henry Badu, who is a senior lecturer in anesthesia, to talk about the practice of anesthesia for cardiovascular surgery.
Yeah, the topic is the practice of anesthesia for cardiovascular surgery. And I've concentrated on the experience at the Kolebu Teaching Hospital, where the National Cardiothoracic Center is. My outline will be as follows. Just a brief history. As we've been told, the National Cardiothoracic Center was commissioned in April 1992, and the first open heart surgery took place in 1992. Initially, 2 German physician anesthetists joined the center in 1991 to carry out cardiothoracic anesthesia. Dr. Thies, who left after 2 years, and Dr. Hans Martin Barwasser, who stayed on until 1999. Mr. Felix Fonder, a German-trained Ghanaian nurse anesthetist, also joined the center in 1992. In 1997, Dr. Ernest Anite joined the center and became the director of anesthesia and intensive care of the center. Dr. David Kote joined the center in 1998. Dr. Ahmed Zakaria worked as a physician anesthetist at the center from 1998 to 2000, and more recently, Dr. Ernest Ofosu-Appiah joined the center in 2009. Of course, these are the cases under general anesthesia, so they would not include the many cases of pacemaker implantation that are done. In 1997, there were 150 cases done in the center. 65 were cardiac cases, 50 were thoracic cases, and 35 were other cases such as some vascular cases, thyroidectomies, etc. In 2012, 287 cases were done. This included 139 cardiac cases, 81 thoracic cases, and 67 other cases. In 1997, this is a breakdown of the cardiac cases. These were all got from the anesthetic records, which are available. 6 PDA closures, 5 BT shunts for tetralogy of Fallot. I won't mention all of these, but you can see them on the screen. VSD closure, ASD closure, total correction for tetralogy of Fallot. And then mitral valve replacements, aortic valve replacements, combined aortic and mitral, quite a few pericardial windows for pericardial effusion, pericardiectomy for constrictive pericarditis, etc. In 2012, the cardiac cases, PDA ligation 17, BT shunts for tetralogy 27, total correction 14, ASD and VSD closures 10 and 17, and a few single cases of combined defects. Again, a few cases of combination of things like ASD, VSD, PDA, and then 11 mitral valve replacements, 5 combined mitral and aortic valves, and then a few other combinations, 2 CABG operations, a left atrial myxoma excision, this time just 2 pericardial windows, and then again pericardiectomy for constrictive pericarditis. There were 3 pacemaker implantations under GA. As I said, almost all pacemaker implantations are done under local, but this included 1 child and then 2 adults who, for one reason I wouldn't know from the anesthetic chart, maybe required the GA, maybe couldn't tolerate just local. Okay, the anesthetic techniques used. The initial techniques used were introduced by the first anesthetist, and some of these techniques have been kept, others have been modified, and some new techniques have been introduced. Initially, for open heart surgery, induction was often with fentanyl and etomidate, followed by muscle relaxation with pancuronium. Nasotracheal intubation was done, and anesthesia maintained with nitrous oxide, oxygen, and isoflurane. When nitrous oxide was used, it was always discontinued at least 10 minutes before going on bypass. As you know, nitrous oxide would increase the size of any air bubbles that might get into the circulation. So that's the reason for that. Later on, the use of nitrous oxide was discontinued, and patients were maintained on oxygen, air, and isoflurane. Midazolam infusion was given during bypass instead of diazepam, which had been used previously. Currently, for most open heart cases, induction is usually with midazolam, fentanyl, and a sleep dose of propofol. Maintenance is with air, oxygen, a propofol infusion, plus or minus isoflurane. This propofol infusion is continued on bypass. Intubation is still by the nasotracheal route, and as usual, heparin is given before bypass and reversed afterwards with protamine. What inotropes are used? Dopamine and adrenaline have been the inotropes used over the years. Milrinone, the phosphodiesterase inhibitor, was introduced later, and because of its vasodilation effects, the loading dose is usually given when the patient is on bypass, 50 mics per kilo, and then infusion is continued after that. Okay, more recently, a combination of dopamine, noradrenaline, and milrinone have been used for patients requiring isotopes. When a vasodilator is needed, GTN is the choice. All major cases have arterial and CVP monitoring for invasive monitoring. Usually a right internal jugular triple lumen CVP line is used, but sometimes a subclavian line is used. The arterial line is usually put in the radial artery, except in small children and infants where the femoral artery line is used. A pulmonary filtration catheter is not routinely used, but it's occasionally inserted when one requires to measure the pressures in the right ventricle and pulmonary artery. This just shows monitoring. Of course, in addition to arterial and CVP monitoring, we always monitor the ECG, pulse oximetry, and end-tidal CO2. It is hoped that facilities for TE, transesophageal echocardiography in theatre, will soon be put in place, and Dr. Kote and Dr. Ofosu-Appiah have had some training in this. In conclusion, anesthesia for cardiac surgery is well established in Ghana, and the hope is to keep abreast with current trends in cardiac anesthesia. Thank you.